is Dr. Rob Durcan, and Rob is a clinical research fellow in the group of Professor Rowe, whose name has already been mentioned this morning, working at the Cambridge Centre for Frontotemporal Dementia and Related Disorders. And Rob's doing a PhD studying the role of the chemical noradrenaline in neurodegenerative disease using novel brain imaging techniques. And Rob's funding for his work is via a research fellowship from the PSP Association. He's also involved in the NORAPS clinical trial, which is investigating the potential benefit of the drug atomoxetine in PSP. So a very warm welcome to you, Rob, and thank you for your presentation entitled Treating Symptoms in PSP with Noradrenaline. So over to you.
Brilliant. Good morning, everyone. Thank you very much, Professor Morrison, and thank you to Dr. Gosh. It's a wonderful talk and quite a difficult act to follow. Reassuringly, in many ways, there's some people on the call who I recognize from having participated in the trial that I'm here to advocate for and to try and raise awareness for. So that speaks to it's great to see you. For better or worse, there's got some overlap in what I'm going to talk about and what Dr. Gosh has spoken about already. So yeah, I apologize for the duplication. Everyone here, this audience is well versed in the litany of problems that are common, but not necessarily universal in progressive supranuclear palsy and in cortical basal syndrome. My talk is going to focus more so on PSP than cortical basal syndrome inherently, but there is, as people are aware, quite a lot of overlap. So early falls, trouble with how your eyes move, slowness in how your mind moves, slowness in the way your body moves, changes in the way you speak, the way words come to you and the way you pronounce those words often, changes in swallow. And I'm very interested in the behavioral change. These are mentioned quite a number of times in Dr. Gosh's work. Behavioral symptoms of apathy and impulsivity, in particular, are a real focus of the research here in the PSP clinic in the University of Cambridge. Unfortunately, many of you may be very familiar that drug treatments are quite imperfect, and even when they work, they don't work perfectly, and often they don't really work at all. Our goals are lofty, but broadly speaking, they're very patient-centered. We want to improve and provide earlier, accurate diagnoses for patients and families affected by this illness. We want better treatments, and then beyond medical treatments, we want to, tie in all of the non-medical and support systems to have a better quality of life for patients themselves, but for their caregivers, their families, and loved ones. I'm speaking about a clinical trial which is being run around a number of sites across the United Kingdom that's really ramping up and accelerating into fifth gear as it comes in, really all full steam ahead, and we're looking to invite participants who may be interested in taking part. This is called NORAPS. It uses medicine that boosts noradrenaline, and we're recruiting for progressive supranuclear palsy. So I'm going to tell you why we're doing it. So because it's treating symptoms which are troubling and are when we're doing it. So it's going to happen now. It's been recruiting over the last number of years, and we're hoping to finish within the next 12 months. Who is eligible, how we do it, and where it's available. So why we're doing it, as Dr. Gosh has alluded to, is that these symptoms are very troubling. What exactly is apathy? So apathy is hard to describe, but it's the lack of motivation, and often this manifests in the person who has PSP feeling as though they can't be bothered. They can be very flat, lethargic, and loss of interest in care around the home, outside of the home, their previous hobbies. And then the other symptomatic feature that we're quite interested in is impulsivity. And this, in essence, is poor decision-making, the inability to make concrete, well-formed, logical plans. And day to day, this can be borne out in things like becoming short-tempered, change in food habits. So, often it's quite a common thing that people will overfill their mouth when eating, as a marker of impulsivity. People will lose safety awareness and they will walk in situations even where it may not be overly safe to do so, and put themselves at risk of falls and so on. Apathy and impulsivity, again, rehashing what Dr. Gosh has said, are, that they associate with each other. So the more apathetic a patient is, often the more impulsive they are. Both of these track quite well with disease severity. So as your PSP moves on, often you become more apathetic and more impulsive. Why are they important? So if you take everyone with progressive supranuclear palsy and cortical basal syndrome, and you were to split them by how apathetic they were, the people who are most apathetic appear to do worse. They on a group level, not necessarily on a personal level, but on a group level, people who are more apathetic have an earlier and quicker progression. They seem to be admitted earlier to care homes if that is their ultimate destination. And there is a signal that the most apathetic people within the overall group may survive a shorter time period than people who are less apathetic, who remain motivated and engaged. Impulsivity, meanwhile, is very clearly associated with carer stress, frustration, and reduced quality of life for carers. Again, rehashing Dr. Gosh's suggestions. From preliminary data within the trial, apathy and impulsivity correlate very well with disrupted quality of life for the carer. So we're treating symptoms which have a major symptomatic burden on the carer and the family of patients with progressive supranuclear palsy. What exactly is noradrenaline? So noradrenaline is a chemical, it's made in our brain, and we know from a lot of work here in Cambridge and elsewhere around the world that the symptoms of apathy and impulsivity are both driven by a lack of noradrenaline in our brain. Noradrenaline arises from a very tiny little structure. Here, you see it as a blue dot. It's absolutely minuscule in the bottom of our brain. And this little blue dot is called the locus coeruleus, which in Latin is the blue spot. And this little blue spot is massively diseased and depleted in progressive supranuclear palsy. So you get excessive aging of this blue spot and resultant loss of noradrenaline. So this clinical trial looks to see, can we improve the symptoms that are troubling, that impact potentially survival, prognosis, and quality of life of apathy and impulsivity. How do we do this? We use atomoxetine, which raises noradrenaline levels. This is a drug that's been around quite a long time. It's used in attention deficit hyperactivity disorder, otherwise known as ADHD. This is an illness really recognized more so in children, but this medicine is safe and has been shown to be safe and well tolerated in other similar diseases, but different, such as Parkinson's disease and Alzheimer's disease, and has shown some trend towards being helpful for cognition in these illnesses. So by treating apathy and impulsivity, can we improve symptoms? Can we improve quality of life for patients? Can we improve quality of life for carers and families? Who is eligible for our clinical trial? So if you have a clinical diagnosis from your neurologist or your doctor of PSP, you are considered eligible, provided you are age 50 to 85. And unfortunately, patients with isolated cortical basal syndrome or cortical basal degeneration don't meet the inclusion criteria of this trial. It is unfortunately just looking at PSP. However, often there is an overlap between PSP and cortical basal syndrome. And if this was the case, you would be eligible for this clinical trial. By the nature of how the trial is structured, you would need to have someone who generally lives at home with you, who sees you daily or certainly frequently, who would be able to fill in questionnaires about your behavior and how things are going for you. And this person would need to travel with you to any trial visits. How does the trial work? So it's 6 visits over approximately 5 months at the study site. Unfortunately, we can't do it at home because there's some testing that really requires to happen in hospital. At your first visit, you see a doctor, and there's some testing to make sure that the diagnosis is correct, that you don't have any of what we call exclusion criteria. We go through the consent process, we take some bloods, and preferably, but not absolutely mandatorily, we invite you to have an MRI scan of your head. Following this first visit, you are randomized. So this is a coin toss whereby you will be assigned to either the top arrow or the bottom arrow. In the top arrow, you would receive the placebo for 8 weeks, followed by a 2-week break, and then the drug for 8 weeks. If you were randomly assigned to the bottom arrow, you would receive the opposite order. You would receive the drug for 8 weeks, then a 2-week holiday, then placebo for 8 weeks. You are seen at the beginning and at the end of each of the 8-week blocks. And again, we do some testing, some blood tests, and it takes a couple of hours at the study site. There's a 6th very quick final visit to make sure that no significant concerns have arisen through the trial. And the MRI scan at the start is encouraged, but it's not absolutely necessary. Blood tests we're using are really to monitor for safety, to make sure that your routine blood work is within normal limits throughout the trial, but we're also looking at markers in blood to understand if we can improve or achieve earlier diagnosis, more accurate diagnosis, improve ways of predicting how your disease may progress in the future, improve ways of predicting how you may respond to the drug treatment. So there's quite a lot of very exciting work to be done on blood tests that arise from the trial itself. For anyone who was considering joining the trial, what are the motivations? Okay, so primarily this is a symptomatic trial. The goal of the trial is to improve your own symptoms. Okay, so this is a drug which plausibly has a lot of evidence to support that it will improve symptoms that you may or may not experience, which are common in progressive supranuclear palsy. Beyond your own improvement, we are unfortunately talking about an illness that does not have any convincing evidence-based treatments for symptoms. So you would be contributing to the evidence base to support symptomatic treatments for patients with PSP in the future. And you'd be joining a fairly well-oiled machine. We've recruited 61 participants so far, and everything is running smoothly, but we are looking to accelerate recruitment over the next couple of months. And we're willing and eager to hear from anyone who wants to hear more about the trial. At present, this trial is available at 7 sites around the UK. And most of the recruits to date have been in Cambridge and Southampton between ourselves and Dr. Gosh. But also there are sites already recruiting in Newport in South Wales, Salford in the Greater Manchester region, Oxford, Glasgow, and Newcastle. While you may or may not attend any of these services for your ongoing neurology care, if you were to live a reasonable distance, and I recognize that is a very vague term, from any of these 7 sites, transport can be supported, and there is funding within the trial to make it as easy as possible for you to attend any research, any clinical trial site. So distance that you live should not be necessarily an obstacle on our end to being able to participate in the clinical trial. We want everyone who has this illness to have the opportunity to participate. If you'd like to hear more, I leave my emails here on the screen, and I'd be absolutely delighted to answer any questions that anyone has about how the trial works, and any questions about what we're anticipating to find. Thank you very much. I'm extremely grateful to the PSP Association for their ongoing support. It's a great honor to be a clinical fellow of the association. And more so, I'm beyond grateful to the patients who participate in the clinical trial. And I fundamentally hope that we can show that these medicines are helpful and provide better better evidence for treatment for patients with PSP in the future. Thank you very much.
Thank you very much, Rob. That was really clear and looks to be a really worthwhile study. And thank you to those 61 patients who are recruited so far. I am encouraging again, folk, to please type your questions in the chat there. We've got quite a bit of time here to go through questions, so please do add your questions. I've got lots of questions, Rob, and so if I may just kick off.
Yeah, of course, yeah.
And just to say, I thought adrenaline was one of those hormones that we're taught about in medical school, that it goes up when we're scared, fight and flight. The lion is about to eat you, so your levels of adrenaline go up. If you're increasing the level of noradrenaline, do people get panic attacks? Do they feel scared? Do they feel stressed, or not?
So, I mean, it is an excellent question, and so if you go back to the first assumption that noradrenaline is low in this illness, so that the factory in your brain, that little blue spot that makes noradrenaline, is extremely diseased. I forgive the word, okay, but it is not operating at full capacity. So your noradrenaline levels are way below normal to begin with. So giving a drug that boosts them, it is aiming to bring that noradrenaline level to normality rather than to give you an excess of it. So it is aiming to bring your system to normal from low, rather than to tip you into a excessive adrenaline state.
Sure. So you're not seeing, so that's there are no issues with people becoming very stressed, or I'm thinking particularly of agitation, because on top of apathy and impulsivity, if there were to be agitation, that would just be, another blow to patients participating, but you haven't seen that so far.
No, not at all. It's a relatively modest dose that's used. And to the trial, certainly of any participant that I have seen in Cambridge, that has not been the case at all. That this trial does not precipitate agitation or a sense of restlessness.
Fine. Thank you very much. While I wait for questions to be uploaded, just another one from me, Rob. If someone is on the trial and then they have completed the trial, no matter which arm they were in on the trial, do they have the option to continue on the medicine, given that it's prescribed for ADHD, so it is available?
Yeah, atomoxetine does have a license for ADHD, and your treating neurologist can weigh up your experience during the trial and make a calculated decision about prescribing off-label, in that, and I use the term off-label in that it is for an illness beyond what that drug is licensed for. So there is scope to have this medicine ongoing if you felt much better during the trial. There's a caveat that your neurologist and everyone within the trial is completely blinded to which treatment arm you are assigned to. So hypothetically, if you felt better during one of the 8-week treatment blocks, I, or anyone associated with the trial does not know if you were better during the placebo arm, so the fake drug arm, or the drug arm. But there have been patients who have here been prescribed atomoxetine off-label following the trial by their treating neurologist.
Great. Thank you very much. I'm now scrolling down. So there's a question here from Kelly. Can people who've been diagnosed with active PSP and CBD participate in the trial, or is it only PSP patients? So if you could go through that again.
Yes, certainly. So people who have what is recognized as an overlap between the two illnesses, so features of both are very much eligible and invited to participate.
Thank you. Rob, I see that you've asked the question about treatment continuation if there was a positive response. So I think that Rob Durcan, our presenter, you've already answered that question. Thank you. So I'll move on to Julie Wilton. Is the upper age limit rigid? My mum will be 86 in a couple of months.
Well, she's 85, so if you contacted now, if she came in at 85, she's fine.
Okay, so
until
Julie,
you're eligible until your 86th birthday.
Okay, Julie, so that's a skates on dash to get on the trial there. So thank you. Scott writes, we live in Devon and my wife has a pacemaker, so cannot have an MRI. Would this make her not qualify? Would we have to get permission from her specialist?
So certainly the MRI is it's voluntary and it's not a prerequisite at all, and there are a whole list of reasons why someone may just decide that they would like to participate but do not want or cannot have an MRI scan. Regarding the pacemaker, it would depend ultimately on some cardiology issues about why it was inserted in the first place. So at risk of giving personal medical advice, so you could contact the trial and we can go through the ins and outs of whether your pacemaker would be or would not be eligible for the trial. But if there are other reasons that anyone did not want to have an MRI scan, be that claustrophobia or any other reason, you would still be eligible to participate.
Thank you. Thank you. So it's an issue to do with the reason why you have the pacemaker would need to be considered by the team.
Yes, so as clinical trials go, this is a very inclusive trial, and we really are very hesitant to say no to anyone for any reason. But the people who govern clinical trial development err on the side of caution, and there is some caution around people who have a history of having heart disease of certain types. So it would just boil down to why you had a pacemaker in the first place.
Thank you. Thank you. So Kristalina Antonides, who I think we'll be hearing from later, she's just put in the chat that Oxford have indeed just opened for recruitment, and they would be very interested in anyone getting in touch with them at the Oxford site. So just to highlight that that's come up in the chat.
Brilliant. Thank you.
Stephanie and Howard have put another question up. Is there evidence in the drug from other trials, and how many people are you aiming to recruit?
Yes, so this drug has a very broad evidence in other completely different illnesses of ADHD and has been very long around time in that illness. But regarding neurodegenerative illnesses, it has been studied in Parkinson's disease and was helpful towards mood, memory, and global cognition, and had a trend towards improving apathy. But the way the trial was designed, this trial is maybe 13, 14 years old at this point. The way the trial was designed was to show improvements in walking rather than in cognition. There's more work to be done, more so on the cognitive outcomes of atomoxetine in neurodegenerative illnesses. There's a currently recruiting trial of it in Alzheimer's disease and memory impairment in the United States, which has shown very impressive improvements of cognition, of memory, of apathy, but also of some markers in the spinal fluid of patients in the trial to suggest that early evidence that this drug may go beyond just improving symptoms and may affect the underlying cause of the Alzheimer's disease itself. Very early, and I'm very hesitant to oversell that. That I think this is primarily a symptom trial, but there is very convincing evidence that it may also slow the illness under the microscope as well. And more work is to come out of that clinical trial from the Alzheimer's disease group from the United States, but also the blood work from this trial. We think will add evidence to support or not support whether this drug atomoxetine can impact the actual disease itself under the microscope. Thank you.
And just before I push you again on the number of people that you're aiming to
excuse me.
recruit.
I've said we have 61 participants and we're aiming for 82, but really the more the merrier. Okay, so the trial for various reasons has to wrap up by into the early next summer. So anyone who comes on board between now and then, the more the merrier. I think pragmatically, we are going to run until early summer 2025, and anyone who can come in between now and then will be more than welcome.
Thank you, Rob. And the PSP research team have put the link for their contact for anyone who's interested in participating to contact them. So it's just to highlight to anybody who might be thinking of it, do click on the link that the PSP team have provided there. So another question, would someone who doesn't have apathy but just impulsivity be accepted into the trial?
100%, yes. You would be. We're not limiting recruitment to any change in your behavior. There are people who have participated in the trial who have neither apathy nor impulsivity. And that's important that everyone who has PSP is included in the illness, because it helps us understand why some people have more apathy, why some people have more impulsivity, and also helps us understand who may respond best to the drug. So if it's come across that we're only recruiting people who have apathy or impulsivity, I apologize, that's not the case at all. We want anyone with PSP, whether you have any change in your behavior or not.
Thank you. There's a question here about, is the trial open to non-UK residents? I think you've sort of answered that. They would probably need to get to a UK centre. Yeah,
so we would support transfer and transport to sites, but I suspect that it wouldn't go as far as transport from abroad, and I think the logistics of that are probably quite difficult to have 6 visits over 5 months traveling from abroad with PSP.
Thank you. So Phil has asked, have you considered alternatives to drug solution? For example, why are the relevant cells failing to produce sufficient adrenaline? Can they be encouraged to work better by other means?
Yeah, so it's an excellent question, Phil. And what I will say is the advice that we give anyone in clinic is that what tasks that make if I go back to that little blue spot in the bottom of your brain that makes noradrenaline, daily life tasks that require attention and focus make that blue spot work harder. Okay, so being engaged where possible, interacting with family, having social engagements, all of these things, there is a lot of evidence that they make your blue spot, the locus coeruleus, work a little bit harder and make a bit more noradrenaline. So an engaging life is also a noradrenaline boost, and we anticipate that is something that will, as a mechanism, also maybe improve behavior. So that's I suppose an encouragement to for carers of patients to support, you know, an engaging, involved, and interesting life.
Thank you. There are a few comments here about the age cutoff for 85, and Delia is asking if that can be pushed. What's the rationale for 85, Rob? I know you've got to choose something.
I wasn't involved in that decision, and it's unfortunate that it exists, and I think biologically it does not make sense, but it is in the trial, and I suspect it's quite a hard limit, and I'm not defending that the trial has the people who have designed the trial for safety reasons have enacted it, but it exists, and I apologize to anyone who would be interested who is excluded on that basis.
Thank you. Now, Amanda has posed an interesting question. Recently, over the last few years, there's been an increase in late diagnosed neurodivergence. Is there any relationship here? And I think she's meaning between perhaps neurodivergence that manifests in later life and PSP. Do you screen for undiagnosed ADHD in the patients?
Thank you, Amanda. That is a very true observation, that adults' diagnosis of ADHD and, you know, being on the autism spectrum disorder is increasing, but our kind of take on this is that they are developmental disorders, which reflect a change in the way your brain develops from early childhood or in the womb even, and PSP is at the total other end of the spectrum, where your brain ages excessively in certain patterns and causing the symptoms that we experience. So I think they are two different processes. In one is the beginning of life, making your brain a little bit different, and one PSP then is at the other end of life, where your brain ages a little bit unusually in with certain areas of your brain aging much quicker than others, and reflecting these changes in movement, swallow, speech, behavior. What this flurry of adult diagnosis of ADHD and autism spectrum disorder has meant that there is increased awareness of atomoxetine, and it is you know, it's a drug in demand across the NHS now. So that's a rambling answer, but no, I don't think they are the same process or inherently linked to each other. But they're both probably associated with a low noradrenaline state.
Thank you. Thank you very much. And I think that we're going to, I'm going to try and wrap a few comments and questions together, just to say that Dr. Gosh has also put in the chat, anyone who lives in Southampton, he would be very happy for you to see you in his clinics in Southampton if you would like to take part in the trial. So he's put the email contact in the chat there. Someone else has asked Rob about mentioning that they're writing on behalf of their mother who can't stay out for long periods. And, you know, trial visits, and I know my long experience of patients in clinical trials, they are tiring. It is a long day. By the time you get to the hospital, you get parked, you get into the unit, it is a long day, even if we try to be as slick as possible. So there's a comment, would you still be able to take part in the trial? And I would suggest that San, it's an email to your local centre to discuss on a case-by-case basis there. One comment that's for you, but I also would quite like if Boyd is still available, about drugs being looked at for CBD. We've had Keppra suggested as an alternative for clomazepam. What's the evidence for Keppra being helpful in CBD? So either you, Rob, that's fine. Yep.
So on the assumption that the symptom that clonazepam is commonly given for is a thing that doctors will call myoclonus, which is often jumpy muscles, for want of a better term. I think that there is good anecdotal evidence. So anecdotal means that it hasn't been through a clinical trial, but it's learned evidence from clinics that Keppra is quite good for that symptom, and certainly it's something that we use here in our movement disorder clinic often as well.
Yes, and Keppra is licensed for that use?
It is not. This is kind of learned evidence from I suppose understanding how Keppra works, understanding what drives the symptom, and putting two and two together. It would be ideal if there was clinical trials to prove that the medicines we use commonly in PSP and corticobasal syndrome are efficacious or not. But unfortunately, most drugs we use haven't gone through clinical trials, and we rely on learned evidence, which is imperfect, and that kind of speaks to that we really need to move the field on and establish clinical trials for these common disabling symptoms.
Thank you very much, Rob. Thank you for your presentation, which was so clear, for the answers to the questions, and thank you previously to Boyd for, again, your really clear presentation and the considered answers to the questions. I think that we're going to have to stop the questions there so that you can all have a break. We'll be reconvening at 11:30. I'm afraid that the IT system here doesn't deliver coffee and croissant to where you all are in your own homes, but we will see you back here at 11:30 for the second half of the